shown this slide a couple times, but just to remember that this is already occurring. And what do I mean by that? We do have a lot of reports of either accidental ingestion, knowing animals that can get into pretty much anything. And as we, as a society, grow to have further access to psychedelics, it's a good chance that there'll be increased access for our pets as well. It's accidental, as we just mentioned, intentional dosing. And so by this, I mean, typically people who've had psychedelic experiences themselves, and then want to either share that or for some perceived for wellness or support, want to either microdose or give a larger dose of psychedelics to their animals. And then we have malicious as well, where there's no therapeutic kind of mindset or hope of providing support and just giving animals doses of psychedelics. And so these are different, and I think we will have to approach those differently as a profession. And last year, ASPCA released their top 10 toxins, and recreational drugs being number 10, but it's rising, it's growing. This group has done a really good job overall. This is kind of a classing of psychedelic or hallucinogenic drugs with other recreational drugs, so including some opioids, cocaine, PCP, things that I wouldn't be considered psychedelic or therapeutic, as we're talking about them in maybe more in that slant. But it does have really good information. So I recommend both this one and a lot of the information that the ASPCA has put out as really, really good baseline information. So this, again, this ASPCA, they have a really good kind of summary of a lot of different illicit drug intoxications. So again, I do recommend having a read through that and as we go into further discussion. And again, this is very much human data, but it lists the comparison of people seeking medical treatment when taking a certain substance. And interesting enough, so psilocybin or magic mushrooms being one of the lowest. Very few reports of people going to the emergency room for this. Cannabis a little bit higher, LSD above that. And then we get into kind of some of the more illicit, or I'm going to say harder drugs, cocaine, amphetamines, and then we have MDMA and ecstasy up there. Okay, so LSD or lysergic acid, diethylamide. So this isn't, they say, is not a very common exposure, at least based on the ASPCA, and I think that's good, that's great. And even when animals do get into it, they don't see too many external effects. I think that would definitely depend on the dose, and you might see, still some kind of swaying, some tremors, some obvious disorientation, but not as maybe profound as you might see with other substances. But the reason though you can get concerned about this or picture a scenario where an animal could get into a very high dose is to remember that LSD is often in micrograms, so 100 microgram dose, which is put on either a piece of paper or a sugar cube or a stamp, or it can come in liquid or crystalline form as well. If a person did have a lot at their exposure, an animal could eat 4 or 5 sugar cubes, you're looking at a very high dose, and at least in terms of psychedelic effect. But generally, this won't be one as huge concern if we know that the animal got into, again, a pure substance of LSD. And also keeping in mind that often people, again, think they have pure substances, especially with LSD, and they do not. And so something always to keep in the back of your mind. But the good news, has a pretty high LD50, so up to there were some reports of giving up to 0.3 milligrams per kilogram in rabbits. Of an LD50 in rats is 16.5 milligrams per kilogram IV. So remember, we're talking 100 micrograms, and this is 16.5 milligrams per kilogram. So this is a very, very high dose. And so if the animal got into this, I wouldn't be too scared, I think that would be very difficult for them to get into, but not impossible. Sometimes LSD they put down into crystals or a liquid formulation that can be very, very potent. So not to say it can't happen, but overall wouldn't be too concerned. And even the ASPCA recommends maybe at home monitoring and care might be more appropriate, knowing that decontamination would be difficult as it could absorb very quickly. And all they would be doing is kind of keeping that animal safe and monitoring kind of like a post anesthesia phase. But one important factor is it can last pretty long, up to a 12-hour normal kind of trip in a human. So I'd be looking at that or longer, depending on how much they actually got into. LSD or MDMA, as far as I'm concerned, those potential could be very, very dangerous and easily cause a serotonin syndrome in our patients. Okay. Benzos as well, even though we might be using benzos to help offset anything that's going to alter mentation or neurological status, respiratory function could be in effect. So other drugs that we commonly use, so mirtazapine, trazodone, clonidine, any opioids, so tramadol, even fentanyl, morphine, anything could have a greater potentiated effect, and phenobarbital as well. And then in general, kind of a further caution, this is, I'm sure, going to be a growing list of things to be concerned or watch about, but if it's pediatric or geriatric patient, any cardiac dysfunction, especially when we're talking about MDMA, liver dysfunction, and then any seizure status, any epileptic or any abnormal neuro signs previous to this might just have different considerations or concerns for your patient. So a little bit more about serotonin syndrome. Often we'll see serotonin syndrome in our patients from accidental ingestion of SSRIs, their human dose, or if the patient is on it and eating too many pills. So we do have some familiarity with it within clinic, and things to watch for. So dilated pupils and the shivering, sweating, tachycardia, or a mild increase in heart rate, a delirium. So this is going from kind of mild to moderate symptoms, and then moderate being this getting altered mentation, and we're just seeing an increase of those signs going into kind of tremors, hyperreflexia, into potentially seizures, and then one of the biggest ones being hyperthermia, right? And so any MDMA patient, I'm going to be watching their temperature, watching their heart rate, watching their blood pressure, and seeing if this is going from just dysphoria or an uncomfortable situation to, I think, a potentially life-threatening situation where we need to get a little bit more involved. So going back, let's say we're not having an absolute crisis, or we're not suspecting serotonin syndrome, we're suspecting, let's give an example of the patient got into several grams of psilocybin mushrooms, appears normal, but we do see a psychedelic effect that is pretty profound. And so the patient's already several hours into this. How do we treat it? And so what's a specific way to monitor a psychedelic patient in this framework? I think IV fluids, venous access would always be safest. Remembering to minimize stimulation overall, dim lighting, even calm music, and then keeping them nice and warm or thermoregulated. Vital monitoring, heart rate, respiratory rate, SpO2, blood pressure. I put this, but I also wonder, right? I wonder about the discussion, and really excited for input of being too hands-on versus hands-off, right? And I can only take this from kind of a human-centric point of view, being handled in that specific state, bright lights, things like this, poking, anything you're going to be, could just make things worse for that patient. So it's really going to come down to clinical judgment and what you think is appropriate. And of course, how much you trust the knowledge of that you received either from the owner. But I think it's something for us to discuss and consider. And so I actually consider or think about think about this in kind of a pre or post anesthesia care, and that it's not much different for me overall. Especially, let's talk more about the kind of post-operative care or anesthesia assessment. And I take this from, if you can see it, so this is from some RAVs, so a wonderful group, and I use this with their permission, of their beautiful chart that they've laid out of assessing anesthetic depth from stage 1 to stage 4. Stage 1, just kind of a quick recap, being kind of a pre-anesthesia phase, where we're not going to see too much changes, but and the patient's not out completely. But there might be some changes in vital signs. Maybe their pupils change, things like this. And then going into a stage 2, that excitatory phase, or I'm going to say dysphoric type of phase, which we also may be able to see in the psychedelic phase. And then getting into kind of a anesthetized phase. I would think we're going to be more in stage 1, stage 2, maybe a light anesthesia phase, or might mimic kind of a light anesthesia phase if they're pretty out of it, but they should still be responsive to stimuli. Anything beyond that, yeah, that would get a little bit scary. I would think of more contamination, or if we're talking super high doses in some of these patients. So I think this is a good chart for us to refer to. And let's say we have our patient, we're monitoring it. Can we use these kind of charts to start to classify, to start to get an idea of what are the psychedelic effects and relate them to what we already know and are comfortable with? And so that's how I will sometimes approach these cases, depending on the situation. Okay. And then what about follow-up care in general? Let's say your patients have done well. You either decontaminated them or not, depending on the situation. They've recovered well. They're going home. We're all happy. But what about long-term or follow-up care? And so I think this is where it gets kind of more interesting. And this is what we'll go to in the next discussion group in a couple of weeks, because we think it's really important. We're knowing that these psychedelic experiences can reopen critical periods in these patients. And depending on the substance, depending on the amount, that could be weeks to months. And so us having a better understanding of this, I think, will help us also approach our clients to be able to say, yeah, this happened now, but we're not quite sure what's going to happen over the next 2 or 3 weeks. It could be, in some cases, a great opportunity to find new behaviors. If there's any kind of inappropriate behaviors or difficult, challenging behaviors within that patient, maybe that's a great opportunity to work with a trainer or behaviorist in that situation. Or are there negative consequences of this that we're seeing within those follow-up periods as well? We don't really know. And so I think this is a good starting point for us to at least have the discussion. And then I'll post more on not this Monday, the following Monday before the next group, and we'll go a little bit more into what this actually means. What is this critical period, and start to discuss how is that going to potentially show up for us as animal health professionals. Good. That's all I have for today. And feel free to reach out if there's any questions that you want to bring up outside of this, or any concerns. Please let me know. I'm always happy to chat about that.